Suman, you can start now.
So good evening, Doctor. I, Shuman, on behalf of Shield Healthcare, welcoming you all in today's webinar. And the topic of today's webinar is recurrent pregnancy loss. And our guest speaker is Dr. Arunangshu Bhattacharya, sir. So before moving into the webinar, let's have a look on our Shield Connect page. This is our Shield Connect page. Here you can find different blogs written by many eminent doctors across India in different topics. And these are the past webinars already we have conducted in our platform by many eminent doctors across India. And this is the COVID-19 awareness blog. Here you can find different blogs related to the COVID-19, which is a very important and relevant topic in today's time. And these are the key opinion leaders. Almost 250 to 300 doctors are currently supporting us this knowledge sharing platform. And this is the PCOS awareness blog. Here you can find different blogs related to or different talks related to PCOS only by many eminent doctors across India. And this is available in many regional languages as well. You can see it is Hindi, English, Malayalam, Tamil, Telugu, Kannada, etc. So I request all the participants, please have a look on this website, as it is a very informative in terms of our subject area. And now it's time to start our webinar, and it's my honor to introduce Sir. Sir did his MBBS from Medical College Kolkata in 1983, DGO in 1986, and MD in Gynae in 1988 from Calcutta University. Sir is the consultant gynecologist for last 34 years, worked as gynecologist in West Bengal Health Service for last 29 years, and now Sir is attached to Murshidabad Medical College as MO. So worked in ICMR project for prevention of preterm labor with Professor Distinguished late N.N. Roy Chaudhary, sir, in 1984. So with this short introduction, I request sir to take over the station, and meanwhile I request all the participants please post your queries on the QA dashboard on the Shield Connect page. So once the program will be over, we shall have a short discussion on this topic with sir. So thank you, sir, and over to you. Is the screen visible, sir? Sir, is the screen visible?
Visible. Should I start?
Yes, sir, you can start. Just 1 minute.
Good evening, colleague, and other persons involved in this seminar. Our topics of discussion today is a recurrent pregnancy loss. So I will discuss in the loss of pregnancy at any stage. It is a devastating experience, and particular sensitivity is required to assessing and counseling the couple with recurrent miscarriage. And it is also very emotionally traumatic, similar to stillbirth and neonatal death. Now, next slide, please. Actually, ideal definition was 3 consecutive losses of recognized pregnancy before 20 weeks of gestation was stamped as recurrent pregnancy loss. It does not include any ectopic pregnancy, molar pregnancy, or in only biochemical pregnancy. It is not included. But nowadays actually more than 2%, if 2 consecutive pregnancies losses abortion occurs, then we stamped it as recurrent pregnancy loss. And 50% of all conceptions fail, and of this mostly are unrecognized. And in even there is delayed period, it is stamped as delayed period. Of these, 13 to 15% of the recognized pregnancies are lost. Actually, in the I'm saying to the who is displaying the slide, on the right side, The window is cutting off my slide, so I cannot read. Yes. No, previous slide, please. Previous slide, please. Can everybody see me? Hello? Hello?
Yeah, sir.
Hello?
Yes, sir.
Can you hear me?
Yes, sir. Yes, sir. You are audible, sir. You are audible, sir. You can proceed.
50% of all conceptions fail, mostly unrecognized. 30 to 15% of the recognized pregnancies are lost, and 90% of these before 12 to 14 weeks. 10 to 20% pregnant women have sporadic spontaneous abortion, and 2% have 2 consecutive spontaneous abortion, and less than 1% have 3 consecutive spontaneous abortion. These are the overall incidence. Actually, recurrent pregnancy loss actually 2% of, according to incidence, it is 2% for a recognized pregnancy. Next slide, please. When you lose a baby, but you are made to feel like it is just a common medical condition, it is heart-shattering. Geo Clark quotes. Next slide, please. Clinical investigation should be started after 2 consecutive spontaneous abortions, especially when the fetal heart activity has been identified in the pregnancy loss, when the woman is older than 35 years age, and if the patient conceives after a history of long infertility. You should not wait for 3 pregnancy to loss. After 2 pregnancy consecutive losses, you should start investigation and treatment, if possible, after finding out the causes. Next slide. Unknown caller. Hello. Hello. Can you hear me?
Sir, you are audible, sir. You are audible, sir. You are audible.
But I cannot see anything.
Sir, your video and audio, both are, your video is also visible, sir, and you are audible, sir.
But I cannot see anything. Hello?
Sir, you are audible, sir.
I am audible, but I cannot see anything.
Slide is not visible, sir.
No.
Just stop sharing and once again please share the slide.
Huh?
Just stop sharing and once again share your screen. Sir, now visible?
No.
Tavan, you can see? Tavan, you can see the slides?
No, I
Yes,
cannot
yes,
see
sir,
anything.
I can see that.
I can hear your sound, but the computer is showing my desktop. So I cannot follow.
Sir, you can't see the slides?
No. Can't see that. Here is one window where Zoom is asking me to sign in. Should I sign again?
Tavan, please help, sir.
Huh?
Sir, we can see the slides, sir.
I
Sir, if
cannot
you can,
see the slide. The problem is I cannot see the
sir,
slide.
sir, you can just leave the meeting and once again please rejoin. So maybe you got some call, so it get disconnected.
Huh?
Please rejoin, sir. Rejoin. Just leave the meeting and again rejoin, sir.
Acha, acha. Okay.
Suman, sir has been logged out.
Yes, yes, sir will rejoin.
Yeah,
Sir is
sir,
joined now.
sir is coming. Sir is.
Sir is joined now.
Yes.
Suman.
Yes.
Now I can see again.
Suman, share the screen now. Share the screen. Sir, now you're able to see?
Okay.
Sir, you are able to see the screen?
Now I can
Yes, sir. Please continue, sir.
all previous slide. Can I see the previous slide, please? Okay. From this. All pregnancy clinical investigation should be started after 2 consecutive spontaneous abortion. What I told, when there is fetal heart activity before the abortions, when the woman is older than 35 years, and when the couple has a difficulty in conceiving, actually history of infertility after before conceiving. Next slide, please. It has got different subtypes. All pregnancy losses with no viable pregnancy followed by a pregnancy losses, and pregnancy losses interspersed with viable pregnancy. So there are 3 different subtypes. Next slide, please. Primary recurrent pregnancy loss refers to couples who have had never a live birth, and secondary refers to those who have had respective losses following a successful pregnancy. These are the secondary. And recurrent suggests there is a persistent cause which must be identified and treated if possible, if the cause is found. Next slide, please. And there are in 50% cases, the cause is determined, can be determined. In 50% cases, it is unexplained. Mostly, if we divide these etiological categories, it should be as uterine, immunologic, endocrine, genetic, thrombophilic, and environmental. Next slide, please. Ideally, after 3 losses, but earlier if high-risk pregnancy, elderly with medical disorders, and a known family history. And how to investigate? Investigate commoner and treatable causes first. Don't order a blind screen. First is history. History is very important. Clarify and document that it is repeated pregnancy loss. Some patient come that they have a delayed period every time and they thought it to be a pregnancy. So if every time the pregnancy test is positive, then it is, and there is period after that, then it should be considered as abortion. Recurrent spontaneous abortion, chemical pregnancy loss is not included. Early pregnancy loss before 8 weeks and after 8 weeks, second trimester abortions and stillbirth. Past obstetric history is very important. Whether in case of secondary RPL, whether there is a history of full-term birth or there is premature birth, where there is any congenital malformation, terms of pregnancy at the time of gestation, whether it is before 20 weeks or before 12 weeks, location of the fetal heart, If ultrasound, diagnosis by ultrasound is the most common in case of missed abortion, whether there is fetal heart can be located or not, it is very important. Is environmental factors which can diagnose by history only is the smoking, anesthetic gases, toxins and chemicals. Actually, those who work, those female patient works in OT, and the anesthetic doctors are said to be high risk for the repeated pregnancy loss. And high risk factors is a lifestyle, obesity, daily caffeine intake, alcohol consumption, use of NSAID. These are the environmental factors. These should be taken into account while taking the history. Next slide, please. Acquired or congenital anomalies. Congenital anomalies is 10 to 15% women with RPL versus 7% in all women. Congenital anomalies found in almost double. And abnormal implantations like vascularity, septum, inflammation, fibroid, sensitivity to steroid hormones, etc. Regarding uterine factor, septate uterus is most common, poorest outcome, miscarriage more than 60%. Fetal survival with untreated cases is 6 to 28%. Though the mechanism is not clearly understood, poor blood supply or poor implantation. In leiomyoma, if it is submucous, in subserous and intramural fibroid, if it does not interfere with the endometrium, then it actually interferes little. But in case of submucous fibroid, the mechanism is their position, and over the fibroid, there is actually poor endometrial receptivity, and also degeneration with increasing cytokine production. So submucous fibroid is more common with recurrent pregnancy. Besides this submucous fibroid, there is endometrial polyps which interferes with the implantation, intrauterine adhesions, curettage after pregnancy complication, traumatizing the basic layer, repeated curettage after, insufficient endometrium, menstrual irregularities, hypomenorrhea, cyclic pelvic pain, infertility. Endometrium is very important. And among the cervical factors, cervical insufficiency causes recurrent mid-trimester loss. And other anomalies, DES exposure, T-shaped uterus, plus minus cervical changes. So first, if to assess the uterine condition, we do first sonohysterography, more accurate than HSG. Different septate or biconvate uterus should be detected by sonohysterography. Hysterosalpingogram does not evaluate the outer contour, but it is ideal for the cavity. And it also detects that tubal patency. And hysteroscopy is a direct look. It is a gold standard, and intrauterine lesions can be visualized whether these are the causes of recurrent abortions or not. Ultrasound is done for presence or location of the uterine myoma and with associated renal abnormalities, because congenital anomaly of the uterus is usually associated with renal anomalies. Hysteroscopy, laparoscopy, MRI, second and third line of additional information which may be required in some cases. A treatment of uterine factor is hysteroscopy. Procedure of choice is if there is a septum inside the uterus, its septum can be excised. Polypectomy can be done, and laparoscopic biomectomy for fibroid, and in other cases, sometimes laparotomy. But if it is not sure that these are the causes of recurrent abortions, any surgical interference may hamper the future pregnancy. That should be keep in mind. Next slide, please. Cervical encircling is associated with the potential hazard. It also should be judged by the risk and benefit. Actually, by ultrasound, the length of the cervix and the internal os diameter is taken as a consideration, and transabdominal surgery advocated in the treatment of second trimester miscarriage, but it is and the prevention of early preterm labor, but only in selected cases. But actually, transvaginal encirclement is a very preferred method. Women with a history of second trimester miscarriage and suspected cervical weakness who have undergone a history indicated encirclement may be offered a serial cervical sonographic surveillance. In women with a singleton pregnancy and a history of a second trimester miscarriage attributable to cervical factor, an ultrasound indicated encirclement should be offered. Now, the after uterine factor, we shift to the immunologic factor. Among the immunologic factor, there are two types. One is autoimmune, one is alloimmune. Among the autoimmune factor, the most important is the antiphospholipid syndrome, APLS, and systemic lupus erythematosus. In alloimmune cases are very rare, and abnormal maternal immune response to fetal placental antigens. In some cases, it is detected that these are the cause of abortions. Among the autoimmune, systemic lupus erythematosus, risk for the loss of 20%, loss is 20%, mostly second and third trimester pregnancy, and is associated with antiphospholipid antibody. Antiphospholipid antibodies, actually 5 to 50% women with RPL may have a antiphospholipid antibody. Antiphospholipid antibody likely induce a microthrombi at the placental site, altered vascularization affecting the developing embryo, and induces abortion. Antiphospholipid antibody actually alters the coagulation standard of the blood. Antiphospholipid syndrome. Next slide, please. A heterogeneous group of antibodies detected against phospholipids and or phospholipids binding protein. The commonest is the APLS. And antiphospholipids are anticardiolipid and lupus anticoagulant. The in vivo mechanism responsible for thrombus and fetal loss is uncertain, but several pathways are suggested. One is APL is binding to a phospholipid which interferes with the coagulation cascade and act as a procoagulant. And annexin V is with APL placental thrombosis, and it causes placental thrombosis and infraction. These are the dramatic presentation of the antiphospholipid antibody, how it affects the trophoblastic differentiation, proliferation, invasion, thus impaired implantation. Next slide, please. And alloimmunity, diagnosis of alloimmunity is a cross-matching with husband lymphocyte, transfusion of husband's lymphocyte, pure suspension of husband's lymphocytes of blood injected. But these are the alloimmunity is the very rare cause of recurrent abortions. Immunologic factors is immunostimulating therapies like leukocytic immunization or immunosuppressive therapy. Immunosuppressive therapy can be done by progesterone. Next slide. Progesterone. Because it inhibits the TH1 immunity and shifts from TH1 to TH2. Actually, TH1 is receptive and TH2 is abortive. And it is administered intramuscularly, intravaginally. It may increase the local and intrauterine, intravaginally may increase local intrauterine concentration, avoiding any adverse systemic side effect. But the patient preference is it should be administered either by orally or by intramuscularly. And during pregnancy, intravaginal applications of the steroid or progesterone, they may not lie. It should be considered. Next. Mild endocrine diseases like thyroid disease, sometimes poorly controlled hypo and hyperthyroidism, particularly if it is present with thyroid antibody, then it may cause repeated abortions. But there is no strong evidence that thyroid only is the cause of repeated abortions. Next slide, please. Diabetes mellitus. Poorly controlled diabetes mellitus may be a risk of miscarriage. But diabetes mellitus is usually associated with all complications like premature labor, big baby, and associated hypertension, and all complications. But it is not the sole cause of only diabetes mellitus. Today, there is lots of treatment for diabetes mellitus. So poorly uncontrolled diabetes as a cause of recurrent abortion is very rare case, little cases. Next slide, please. PCOD, polycystic ovary. If some polycystic ovary morphology itself does not predict an increased risk of future pregnancy loss among the ovulatory women with history of recurrent miscarriage and conceived spontaneously. Actually, polycystic ovary is usually present with infertility, and every polycystic ovary patient behaves differently. There are many polycystic ovary patients, they actually conceive, and repeated recurrent pregnancy loss, though associated with PCOD, but it is not the very important factor. The problem, PCOD problem is the infertility. And hyperinsulinemia, level of plasminogen activator inhibitor implicated in the proximate cause of the incidence. Metformin is given for the PCOD. It is a treatment nowadays. Luteal phase defect is also very difficult to diagnose. It should be diagnosed before pregnancy, and for the if endometrium is not properly developed, the pregnancy may not continue. So we actually, in immunological cases and also in suspected cases of luteal phase defect, we give progesterone. As a defect in the corpus luteum impaired the progesterone production. However, luteal phase defect cannot be diagnosed during pregnancy. It should be diagnosed before the patient conceives. Next slide, please. Hyperprolactinemia is very rare cause. Only hyperprolactinemia is a very rare cause of infertility, recurrent pregnancy loss, insufficient evidence. There is no actually proper evidence that the only hyperprolactinemia is the cause of repeated pregnancy losses. So, what should be done for an investigation? Thyroid should be done, glucose tolerance test, hemoglobin A1C, serum prolactin, FSH, LH, and progesterone. These are the investigations you should have done. Treatment of luteal phase deficiency. Luteal phase deficiency support with progesterone, but there is insufficient evidence to evaluate the effect of progesterone on supplementation in pregnancy to prevent the miscarriage. The insulin sensitizing agent in PCOS we treat with metformin, overt diabetes, good pregnancy control, and thyroid hormone replacement for severe hypothyroid. It should be investigated. And chromosomal abnormality, 3 to 5% of the couples with recurrent miscarriage, one partner carries balanced structural chromosome anomalies, 5 to 10% chances of pregnancy with unbalanced translocation, even if present, may not be the cause. Complete evaluation of the RPL is indicated. Actually, for a simple fast abortion, actually spontaneously fetus may be chromosomally defective. For which fast pregnancy may loss. But the repeated pregnancy losses, chromosome play very not very significant role. But if you suspect that there is a chromosomal abnormality, both father and mother's total chromosomal investigation should be done, like karyotyping, etc. Thrombophilia, thrombosis on the maternal side of the placenta, impaired placental perfusion, late fetal growth, IUGR, abruption, PA, actually in case of high-risk pregnancy, repeated pregnancy loss, and in case of high-risk pregnancy, we actually give blood thinner so that the placental thrombosis is not occurred. Low molecular weight heparin, some progesterone. Progesterone is not the blood thinner, and ecosprin, low dose aspirin, which actually given empirically sometimes in case of repeated pregnancy loss. And in also high-risk pregnancy with IUGR, PIA, abruptio placentae, etc. Inherited thrombophilic defect, including activated protein C resistance, most common due to factor 5, deficiencies of protein CS and antithrombin, hyperchromocysteinuria, and prothrombin gene mutation, established causes of systemic thrombosis. Any blood coagulation disorders, antithrombolytic therapy is combined of low-dose aspirin and submucous unfractioned heparin given. Low-dose. Environmental chemical states, anesthetic gases, sporadic spontaneous loss, no evidence of association with RPL, personal habit, obesity, smoking, alcohol association with the RPL is so clear, but it should be advised as a part of the treatment. Male factor, trained towards repeated miscarriage with abnormal sperm. In less than 4% normal sperm chromosome aneuploidy, parental HLA not sharing, not risk factor for RPL. Advanced paternal age may be a cause of the risk factor for the miscarriage. Particularly the total sperm count, normal sperm counted percentage is very, very important. And in some rare cases of Listeria, Toxoplasma, CMV, primary genital herpes may be a cause of, but we do not investigate for infections from the first time. Next slide, please. Decreased ovarian reserves. Quality and quantity of the oocyte decreases. Women with unexplained RPL have a higher D3 FSH and E2, even women with the known cause. Actually, infertility and repeated pregnancy loss is associated with aged female partner aged more than 35 years. The use of empirical treatment in women with an unexplained recurrent miscarriage is unnecessary and should be resisted. Some doctors prescribe low-dose aspirin, subcutaneous heparin, folic acid, progesterone, increased oxygen supply, tocolytic agent, duvadilan, tidilan, etc., with often surprisingly beneficial outcome. But actually, if we cannot diagnose the exact cause of repeated abortions, it should not be given in every cases of high-risk pregnancies. Next slide. Summary of the guidelines for the College of Obstetrician for the year. Next slide, please. A woman who has suffered a single sporadic miscarriage has an 80% chance of a woman with 3 consecutive miscarriages. 40 to 60% chance in her next pregnancy being successful. It should be kept in mind if after 2 or 3 abortions, there is 50% chance of a successful pregnancy. This should be conveyed to the mother, where they 2 or 3, because they are mentally so shattered. Actually, they do not think of future pregnancy. Thank you for your patient hearing.
Thank you very much, sir, for this nice presentation. Meanwhile, I received few questions, sir. So if you allow me, then I can access on that. Sir, the first question is, as you mentioned that in case of fibroid treatment, means surgery is the only way, and there is a chance for the RPL in that case also. So what can be the ideal treatment in the case of fibroid for chances of as there is some chances in the surgical problems associated with the infertility?
No, my opinion is that if it should be first the recurrent causes of other causes should be excluded firmly, and you should establish that the fibroid is the only cause of this recurrent miscarriage. Then you should interfere with the remove the fibroid, and it should be a microsurgery without much. If it is done by open surgery, there is a much chance of infections and other complications of the operation, so that the chance of next pregnancy is also become remote for this surgery only. The first thing is that you must diagnose that fibroid is the victim, fibroid is the offensive agent, and there is no other offensive agent for this recurrent miscarriage. And then you can go for fibroid surgery, preferably with laparoscopy.
Thank you, sir. And sir, what is your practical approach in case of RPL in second pregnancy? What is the investigation and how do you think in case of second pregnancy?
In second pregnancy, if there is a history of first pregnancy, I actually do not think of the male factor. Because as there is a successful pregnancy, the male factor may not be contributing. Then I will in history I will particularly I will investigate what is the type of delivery, what are the if cesarean section was done, what is the recovery, whether after the delivery any cause of this recurrent miscarriage is occurs or not. That should.
Thank you, sir.
Vigorous curettage can damage the endometrium. In after a second pregnancy, if there is an abortion or a missed abortion, in some cases there is a vigorous curettage as well as the infection is not properly cared of, and it causes the secondary infertility as well as repeated miscarriage.
Thank you, sir. And sir, another question is in case of chromosomal abnormalities. How can this practice how can you approach on that if you find a person with chromosomal abnormalities? So is there any chance for any pregnancy also?
Actually, in cases of chromosomal abnormality, if it is a case of recurrent miscarriage, it is very difficult treatment. And actually, there is when you can detect only in there is no part of the treatment that the chromosome is corrected. Only the Down syndrome, the patient survives. In other cases of trisomy, other trisomy cases, 18, 13, if it can be detected, actually, it is not survive. The fetus usually does not survive. So in the treatment part, if only the chromosomal part is involved, then the hope is very poor.
Thank you, sir. And sir, I could not find any other question. So if you allow me, then we can conclude this session, sir.
Okay.
So thank you very much, sir, for your valuable time in our platform and for such a nice discussion on this RPL, which is very much important topic in nowadays also. And we look forward some valuable session for you from near future as well, sir. So thank you very much, sir, and good night.
Also thanking you, the Shield team, for
Thank you, sir.
give me the this opportunity. Thank you.
So pleasure, sir, to have you on board with us.
Okay. Should I leave the meeting? Hello.
Yes, sir. Yes, sir.